Hello and welcome back to this teaching series on lung ultrasound. In this presentation, we're going to be discussing the application of lung ultrasound for investigation of pleural effusions. So traditionally, identification and monitoring of pleural effusions sat very much within the remit of our chest x-rays, where if present, you would find that a fluid level could be very easily identified on a just standard plain film chest x-ray, giving us an indication that there is a amount of fluid outside of the lung, but within the thoracic cavity itself. However, due to the poor sensitivity of chest x-rays, the differentiation between pleural effusion and consolidation can sometimes become a little bit more tricky, especially when there's some mixed pathology going on within those lower lung regions. This is where lung ultrasound can really come into its own. So in regards to lung ultrasound, identification and monitoring of pleural effusions is probably one of the most established applications of the use of lung ultrasound across all of the areas where it's used. If we were to suspect a level of pleural effusion within that thoracic cavity, the way that we would start to investigate that would be we would first look at our dependent zones, so looking at probably our lateral chest wall just above the diaphragm, as you can see on the picture here. And we can look posteriorly as well, especially if we've got patients who are laying supine in bed. And what we would find with the lung ultrasound, it would be very clear to see fluid within that pleural cavity. It comes up as a dark or anechoic or hypoechoic space between the pleural layers. So this can be, if it's quite a large pleural effusion, you might find that it moves up to the anterior and posterior zones, and you might be able to visualize it between the rib spaces. But initially, we should be looking at the area just above the diaphragm on the lateral chest wall. And you can see here, looking at the imaging, we can start to identify the level of fluid that is present within that pleural space. So in regards to evaluation of the size of the pleural effusion that you might be seeing if you identify that there's a fluid level within that thoracic space, there are a number of sizing guides that are available which can give quantification of the amount of effusion that you're seeing. Probably one of the most or the better known sizing guides is Liechtenstein's. It's called the Plaps Index, and it's where we're looking to measure the distance between the pleural line, whether that is from the diaphragm to the base of the lung that you're seeing, or if that's a larger effusion and you're looking laterally up the chest wall and you don't have the diaphragm as a guide. You could measure from the chest wall to the pleural line that you're seeing within that rib space. And what we're looking to do is we're looking to see the largest, so the greatest size volume that we can potentially measure in any of those spaces, and it can start to give us an idea of the size of the effusion. So just using our very basic caliper measures, Um, you can do this in real time, or you can just utilize a frozen image where you're seeing the largest available space for you to measure. And Lichtenstein gives a guide that if you can measure in centimeters, you can equate that to a volume in mils. So, although pleural effusions are most easily identified within those dependent lung regions, which we've discussed before, so at the diaphragm level, trying to look for the greatest size either on the lateral chest wall or inferiorly, posteriorly and inferiorly, looking for the largest point. Sometimes it's not always possible to assess the patient at those posterior lung regions, and sometimes you're not able to visualize the diaphragm. So with volumes of pleural effusion that are more significant, utilizing the PLAPS point that we've discussed previously from Lichtenstein, we can identify what's called the quad sign. So if we were to look for example, in a supine patient, if we're looking for the pleural line and between two of the rib shadows, we can draw a kind of a quad sign between the thoracic wall, the two ribs, so the rib at the superior and the inferior aspect of that rib space, and then identifying or drawing a straight line across the pleural line itself. You'll see in real terms, so if we were to find a space of free fluid between two of our rib spaces, we can identify those lines that I discussed before. So looking at the rib space above and the rib space below, drawing a line across, an imaginary line across the thoracic wall, and an imaginary line at the juncture of the pleural line that you can see. And what we're looking to do is measure the largest space between those 2 points. And looking just at a basic caliper measurement or utilizing the marker points on the side of our screen, the centimeter marker points at the side of our screen, we can start to get an indication of the size. And as if we follow Lichtenstein's guide, which gives us an indication of fluid, an indication of centimeters into mils, we might see that the measurement that we've taken here is about 2 centimeters, indicating approximately between 3 and 600 mils of fluid within that thoracic space. So just to give you more of a written definition of just what we were discussing there with the quad sign, this just gives you some information about how to undertake the measurements that we were discussing using just the normal 2D mode or your M mode caliper type of measurements for finding your quad sign. So, although the Lichtenstein method may at times seem a little bit complicated, trying to identify quad signs and looking for caliper measurements in dependent lung regions at the diaphragm or posterior aspects of the lungs, it's probably one of the most straightforward calculations. There are, of course, other methods that you might want to utilize for evaluation of these pleural effusions. Some of the more notable ones I've listed here with some some of their methods of how you would go about undertaking these methods. I would say probably in practice, most of the time, calculations are probably not necessary or probably worth your time. I would argue. In practical terms, one of probably the most recommended methods is just eyeballing the volume of fluid that you would think is within that thoracic cavity. The more pleural effusions you see, the better able you are to interpret the approximate volume of fluid that might be within that space. So I've given some good examples here of what you might consider as a small, a moderate, or a large effusion. In most cases, what I would say that is if when you're in your dependent lung region and you're at the diaphragm level, if you're seeing fluid that is essentially making up just the costophrenic angle, or what would be the costophrenic angle on your chest x-ray, that there's probably a smaller volume of fluid within that thoracic space. Obviously, it depends on the size of the individual and how much of the inferior aspect and the posterior aspect you visualized. But in most cases, it's someplace between 100 and 500 mils, and certainly not worth or just you wouldn't be justifying in draining that amount of fluid. If we look at more of the moderate size effusion, so this is where if you're seeing a fluid level that's not only just making up the costophrenic angle, but it's making up most of the base of the dependent lung region, so that space between the diaphragm and the inferior aspect of the lung. And if it's completely cutting off your curtain sign, then you would estimate that someplace between 500 and 1,000 mils or 1 liter. For larger size effusions, you would most definitely not being able to visualize the lung in any real terms, or if you are visualizing it, it's going to be atelectic, so it's going to be compressed by the level of fluid that's within that thoracic cavity. And this would be definitely worth draining in real terms because it's going to be definitely with over a liter at that time. Like I said, the more pleural effusions you see, the more you're able to interpret the size of those effusions. However, the value of lung ultrasound sits not only in interpreting whether it is a small, a medium, or a large effusion, it's also in interpreting what's going on with that lung itself and what's going on with that fluid that's within that cavity itself. So we're able to identify a lot more readily whether that fluid is a transitate type of fluid or an exudate type of fluid, looking at the type of fluid that you're seeing within that pleural space. So you'll notice that on some of the previous imaging that I was showing you, that effusion appeared to be very dark and very black, indicating to us that it's more of a simple type of effusion. It's made up of probably more of a transitate type of substance. Although you're not able to define whether that is fluid or blood, but what you can say is that it's not started to hemolyze in any way. And it doesn't look to be an infected type of fluid. If you start to see fluids that look more complex in nature, so you've got these septations, and you're seeing that there are particles within that fluid itself. It's giving you an indication that it's more of an inflammatory type of exudate type of fluid that is going to be more likely to be infected. Or it has been there for a longer period of time, so it's allowed those proteins to develop and to form into a denser type of fluid that's going to be a lot more difficult to drain if you needed to do that. Another way that we can start to interpret the type of fluid that we're seeing within that pleural space is to look at what we would call the sinusoidal sign. So the sinusoidal sign is a way of us interpreting really the viscosity or the density of that fluid that we're seeing within that pleural space that can give us some more indication, because as I was saying before, with a transitate type of fluid, especially or a dark black type of fluid, you can't really interpret whether that is blood or whether that is just a simple transitate that you're getting a fluid within that pleural space. Utilizing this sinusoidal sign, we can start to interpret more readily that viscosity. So in order to do this, what we would need to do is we would need to place the probe that we're using, whether that's a linear probe or a curvilinear probe. We would need to place that to visualize that pleural line, because what we're really looking at here is we're looking at the movement of that lung tissue and how freely that lung is moving within that fluid to give us an interpretation of how dense that fluid is, or how viscous that fluid is. So by visualizing the pleural line between the rib spaces, we can drop a simple M-mode through that pleural line, and we can look at the movement pattern that is developed from that M-mode. And what we'll see is that with a fluid that is less dense or less viscous, we will see that the movement of that pleural line within that fluid is going to be greater than if the viscosity of the fluid is higher, which would restrict that movement of the pleural line more readily. There are some common measurements that we can look at, and I think it gives you here an indication here that if we were to measure that movement of the sinusoidal sign, a 15 millimeter expiratory thickness is the minimum that we would consider for a diagnostic puncture, so that we could safely aspirate some of that fluid. Here, so just to give you some nice images of some of the effusions that we might see within our critical care environment. So we've got, again, looks like quite a simple effusion, although it looks like a sea creature within that. We do have a collapsed lung that's probably causing compression because of the fluid within that pleural cavity itself. You've got a little bit of aerated lung tissue at the top. You can just see some B-lines coming in, some consolidation, and then some dark black fluid below. So probably would benefit from draining this fluid. It looks like a moderate to large size effusion that might help to open up and aerate that lung a little bit better without having that fluid compressing the lung at the base there as well. Talking about the difference between our simple, our transitate, and our exudate type of fluids, you can see that there's In this picture, although it's backwards because the pointer is the wrong way around, it's a phased array probe that we're looking at here. You can see that the fluid itself has got these particles in it, giving us some indication that there's some bigger particles within this fluid. Not knowing specifically what that is, that could be lung. That could be blood tissue, that could be infected type of tissue within that lung. But what we do know is that that fluid itself doesn't look to be very clean and very healthy. So definitely, again, draining it would probably be beneficial to the patient from a long-term. So progressing on from some of the images that we were seeing before, where we've got more of a protein-rich or a more viscous type of solution within that thoracic cavity, well, we might find that over time that starts to develop into more of an organized septated type of effusion that can cause some complications in the long term for the patients. Looking at here, what we can see is that we've got the diaphragm at the posterior aspect, as we're seeing in a curvilinear. You've got some indication of the lung just above there, although it doesn't look to be very well aerated. It looks quite dense, consolidated in nature. And then we've got these well-formed septations that are kind of floating around in this the pleural effusion that we're seeing below. A little bit more difficult to start to drain these because you'll find that some of the fluid stays within those pockets of the septations. So it can be a little bit more tricky and it can cause some complications with adhesions and things long term for those patients. Again, another view of some septations that we're seeing, again, more defined. You can see that they're tracking from the base of the lung to the diaphragm, and the excursion of the diaphragm, again, in this picture, is pretty poor, not moving much with the respiration pattern that we're seeing. And again, the lung isn't aerating up in the way that we would hope it to. And then even long term, we're back to that backwards image that I was showing you before. Although I think we can all appreciate that the excursion in this case is much, much better. The adhesions are actually, or the septations have turned into adhesions in this case, are much greater as well. There'd be very little success in probably trying to drain this effusion that we're seeing, although it doesn't look to be significant in terms of size. It's probably tracking up higher up the lateral aspect of the chest wall, because we can see that the adhesions are forming and attaching to the diaphragm there. And finally, just to finish off with some of the lovely images that I was showing you of pleural effusions, I think this is quite a nice case. This was an ECMO patient that we had that actually had a massive bleed within that thoracic cavity, and you can see that the density of that fluid, or what was fluid at one case, within that thoracic cavity has become very dense, echogenic, so that we can actually directly visualize it. I've shown it in two different imaging techniques, so using our phased array probe at the top, and then using our curvilinear probe at the bottom. And it's very difficult to see the difference between where the fluid or the clot within this cavity and where the lung starts. Obviously, this patient would have had to have been surgically evacuated of this collection within the thoracic cavity itself. So, just in summary about what we've been discussing with regards to lung ultrasound for assessment of our pleural effusions. So, um, the sensitivity of lung ultrasound and the utilization of lung ultrasounds for investigation of pleural effusions should be considered superior to that of just our plain film chest x ray. In fact, it's very easy to miss up to about 500 mils of fluid within chest x-ray, and looking at the difference between consolidation and pleural effusion with chest x-ray is also inferior to that of lung ultrasound. The value of lung ultrasound is not only in the identification of pleural effusions within this space and ability to quantify that amount of fluid within the pleural space, but also in the ability to identify the type of fluid that you're seeing, whether that's a transidate or an exudate, and identification of also of any septations or densities, so something like a blood or clot within that fluid that you might want to be aware of if you're thinking of draining that. Always remember that effusions are most readily found within your dependent lung region. So, looking at your inferior aspects at the diaphragm and at the posterior aspects, especially with our patients who are laying supine. Um, and I've given you some indication as well about how you can look to measure those using different calculation methods, or whether you're going to eyeball that method or eyeball that volume as well.